Hi, this is Dr. Randy Grill of the Nursing Home Dentist, and here to talk about making dentures on seniors in full-time care. Mom or dad have issues or they wouldn't be under full-time care. Adapting to dentures. In my private practice, like I say often, I graduated in 1976. Always enjoyed dentures, went into private practice, and actually owned a denture clinic for years. Have had a special interest in dentures and feel like I've been on the cutting edge for that for since the early 80s. I've made probably as many dentures um, just in the couple years I owned a denture clinic than most dentists make in a lifetime. And in fact, when dentists would find out how many dentures I made a month, they said, "Boy, you have a tiger by the tail." No, I enjoyed people. I enjoyed it. I was there for them, and I was honest up front with them on how I could do. We didn't have many implants back then. They were big implants, and they failed. But it's getting pretty good now. The problem is with my patient group, most of them don't have the bone, they don't have the health to heal correctly, and implants aren't appropriate for them. So in adapting to dentures back in 99 or 2000 when I started, I would go in, I'd make the upper and lower denture, and lo and behold, I had a very high percentage of failures. Now, in private practice, when somebody would come in from a nursing home, they'd come back once or twice for an adjustment and I'd never see them again. Now I know why. It's because it's such a hassle for you, the POA or whoever is in the care after 2 or 3 times. It's difficult to get them in. When I would take my mom out, even to Walmart, it was a whole day event because she'd get tired and have to sit down. She'd get interested in something or find somebody that would listen to her. And she was a sweet little 5'02", blue-eyed grandma, and could be a magnet to anybody. And so it's not just a dental appointment like we do. We run in, we run out. That's part of our day. It's an event. In fact, the amount of perfume that used to choke me on my nursing home patients when they would come out to the dental appointment. I don't experience that now because they're not going out. They're not getting all dolled up for something. And I say she because 90 to 99% of my patients are female. So I had a poor success rate. And when dentures aren't worn and they're expected to be worn by the daughters, by family members, you can trigger failure to thrive, depression, they feel horrible. When in the fact, an upper denture like this one, all that front area gets suction on the upper. Most upper dentures do just fine. Unless the mouth is real dry and there's absolutely no bones when they need implants to actually hold them in. Once in a while the tongue will get so big, and that's in our macroglossia, a number of meds, even congestive heart failure, edema from needing, and they're on Lasix, different things like that. Their ankles swell, and so what do? They put them, the medical treatment for that is you put them horizontally, squeeze all the liquid up to the heart. But the tongue is the most vascular muscle of the body, so it thickens. Dilantin thickens. I mean, you name it. The University of Iowa teaches that. It's very seldom found in literature, but for those that deal with seniors that can't get out, once they're in a wheelchair and they're unable to exercise, the exercising in nursing home doesn't get the heart pumping, even when you're transferred, different things like that. So there's 1,000 challenges today on why dentures can't be adapted, but I found a solution, and that solution is I make the upper denture, and they get used to that. We adjust their diet, hopefully mechanical soft, nothing more severe than that. We adjust the diet. We give them 3 months to wear the upper. They get used to it. They begin to get a little muscle memory to hold it in, because the upper is the simplest of the two to get used to. And if when we take the bite relationship for the upper and lower, 99% of the time, I cannot get an accurate bite. I can't get their jaw back into what's called centric relation. They've acquired bites from years of wearing dentures. And we have to remember that many of my patients have been underserved their whole life. You have to be on Medicaid or Medicare to get this insurance covered by the government. Many people, just like my father-in-law who's in the nursing home, we just sold the farm. He has money to spend down, but he probably won't cooperate. We just won't go on about it. Is it worth the $60 for the family to pay it a month? It's up to the family, but many of my patients have been underserved their whole life, and they've worn dentures. I get it all the time since their 20s, 30s, and 40s, and now that they're 80, they've been wearing dentures 40 years. Their jaws have totally worn away and nerves are exposed, and that's covered on the lower denture, the loose lower denture video. So adapting, we found greater success by making the upper, and then the bite relationship is easier for them to make due to their challenges. Sometimes it's hard of hearing. They say open, and I say open, and they close, or I say close, they open. They're confused. They get agitated. Either I talk too loud or too soft for their hearing. It's just lots of stuff. They could have had insomnia. They may have constipation. You just don't know what they're in. So getting a bite relationship for upper and lower is near impossible. And what happens is you make that and you guess where to put things, and they don't adapt to either of them. So this way, we get the upper adapted. It fills out their mouth. They can smile. They feel better. And then that gives me a greater chance to make the lower work. And after about 3 months, we evaluate that, and we go in, and we take a bite, and we do the best we can, and that's the best way to do it. So most of the time, unless a person's very alert or younger, we make the upper denture, get them used to it, see how they wear it. Because if I put both of those in there, and with the flat gums, or even having gums with dementia, loss of muscle function, GERD, you name it, all their challenges, it's a choking risk to have them both in. So get used to the upper, then we'll evaluate for the lower, and if we can, we'll make the lower, or if they'll even allow us or be able to give us the bite then. But this will give you a little clue to some of the challenges that we face and make sure you don't put expectations on mom with your life, wanting her to go to church, have all of her teeth in. If we can just get that upper in, she'll look good. She won't eat better with the lower. Nobody does. In fact, you chew with 140 pounds of pressure with your natural teeth, and 40 pounds of pressure with that, but you take away the gums and it's less. And so the lower denture, even for younger people, is difficult. I have a number of nurses that do not wear their lower denture, and they're under 60. So thank you. This is Dr. Randy Grill, nursing home dentist.